Lazima uende uangalie mama kama alienda kliniki, ukijua unaandika ujumbe NCV.
We train them on how to use these basic mobile phones to help them to communicate with medical officers and the health facility, as well as to improve the communication with their clients who are their people.
Katika hii simu imetupa mabadiliko makubwa. Wakati huo mbeleni ilikuwa ninatumia tu vitabu ambao ninaandika, mpaka pia nitumie miguu yangu kutembea, nimfesi mama, nimuulize. Lakini sasa nilipopata hii simu imekuwa ni kazi rahisi.
Sasa kumsajili mtoto, nitaanza kusajili kwanza wewe mama. Ninapenda, yani moyo wangu unafurahikia kwa sababu wakati wote nitakapokuwa na shida, ninamwambia tayari daktari wangu wa nyanjani na anapeleka ripoti kwa daktari mkubwa huko. Pia nasikia kupendezwa sana.
The advantage of Medic Mobile, it lowers the time taken from reporting from rural area to the facility.
Scroll down from the other side.
So you have a picture of what happened in all the facilities for the diseases that have been monitored, like malaria, typhoid, and TB. Something that could take you 1 month to be able to analyze, it can actually be done in a single day.
Healthcare hasn't been reaching the world's poorest people. And it's not because we don't have the medicines they need. It's not because those medicines are too expensive. It's because a lot of places are difficult to reach and hard to organize a health system for. Take the example of immunization. The World Health Organization estimates that between 2 and 3 million lives are saved every year through standard immunization programs. But another 1.5 million lives are lost due to diseases that are vaccine preventable. Now, vaccines are among the most cost-effective health interventions ever developed. The problem is not the ability to purchase the vaccines. The problem is that it can be incredibly difficult to deliver them to rural facilities. So you end up with stockouts. And many patients live so far from the nearest clinic that they never make it in for immunization. So at the end of the day, 1 in 5 children globally hasn't been immunized. We need to get better at working in these challenging settings. And one of the reasons that I'm very optimistic we can is that 90% of the world's population now lives within reach of a mobile phone signal. I'd like to talk about the possibility of putting a phone in the hand of every health worker. In this picture, health workers who used to enter their monthly reports with pen and paper and deliver them by hand now are learning to submit the same data using a mobile phone. With the team at Medic Mobile, I've worked on more than 50 mobile health projects in about 20 countries in the last few years. And every project is different, but the big picture is that when healthcare workers are equipped for better communication, they have opportunities to coordinate and to reach more patients. In one project, we looked at the simple act of requesting medical advice or submitting reports. And we found that with a mobile phone, it was 4 times cheaper and 134 times faster than the most common alternatives of public transit, riding a bicycle, or walking. In other projects, we see more children getting immunized, more women receiving appropriate antenatal care during pregnancy. In one project, outbreaks of measles and of meningitis were identified early so that they could be contained. And in still others, we've seen rural clinics less likely to run out of stock because they're submitting their reports digitally. So I'd like to paint a picture for you of what one of these programs might look like. Imagine 2 young parents and their newborn child. Many children are born in communities that are far from the nearest clinic where they could be immunized. But if the community health worker who lives in that village has a mobile phone, she can send a text message to the clinic to register that child for immunization. And then software at the clinic on the appointed day will send an automated message back to the community health worker. And if all goes well, the community health worker will then visit the household again, and the parents will take the child in for immunization. And in an ideal scenario, this is how it works. In one project in India, We started with a baseline immunization rate of 67%. And with this combination of text messages and community health workers, we were able to have a 97% rate of immunization among our enrolled children. But in other cases, some other things can arise. You may need transportation to the clinic and not have money for it. Or as I said before, you might get to the clinic and the immunizations are out of stock. Or the fridge where they're supposed to be stored has broken down, or there wasn't electricity for it. So the nurse may be away. She's at another facility getting ice for the fridge, or she's at a warehouse getting a new supply of vaccines. In the meantime, a whole slew of additional messages need to be sent between community health worker and nurse to update on the child's immunization schedule, which has to be kept track of in a medical record so that no one forgets. This is even before we talk about the health worker who gets on a motorcycle to take immunizations to the rural facility. And then you have the parents who show up at the clinic without ever having met a community health worker. They need to go through a side process so they get paired with the right person in their village. And wow, suddenly this got really complex. And this is an experience that I've had again and again. I show up as a foreigner with a relatively simple idea of what the problem is and a simple idea of how technology is going to fix it. And then real life happens. Organizational messiness happens. The good news is that frontline health workers have a phenomenal ability to improvise, to coordinate their work on the very edge of chaos. But institutional technology projects don't have such a good track record. I'll say it again, I believe we should put a phone in the hand of every health worker, but I also have to tell you the truth is that most institutional mobile health projects have failed to grow or survive beyond a small initial grant-funded pilot. So we have to get better at dealing with this kind of complexity. And this is why I believe it's so important for us to have better conversations about human-centered design. There are a few practices in the design community that I find incredibly helpful for dealing with this kind of complexity. One of them is as simple as spending time in the company of the people we hope to understand. It's about building empathy, and more specifically, seeing things from the point of view of others. I'd like to illustrate that with an example. One of the most common questions we ask of a health worker is, do you have mobile phone network in your facility? And showing up at this particular facility, the answer was yes. And initially we thought, okay, yes, they have mobile phone network. But we didn't pack up and leave. We stayed around a while. We hung out with them and saw what it was like to work in that facility. And before long, we noticed these weird papers in the window. And we said, why do you have paper in the window? And they said, oh, those pouches are where we store our mobile phones. And so we'd ask, well, why do you put your mobile phone in a pouch in the window? And the reply was that this is the only part of this facility that gets mobile phone network. So we put our phones in the pouches, and then we go do our work, and then when we hear a ring, we go running and we answer our phones. So now we could see this question, do you have connectivity from their point of view? And the answer is yes, we have a trickle. And that affects the kinds of design decisions we make. Are we going to send them text messages, or are we going to ask that they rely on a cloud-based web application that will require faster mobile internet? So as you see, when I talk about human-centered design, I don't want you to think only of graphic design or fashion design. I'm talking about our process for making, for adapting, and repurposing technologies. And I'm talking about an approach to technology that puts people first. Another design practice that can be incredibly powerful is to engage workers in the ongoing redesign of the technology they're using. In this particular photo, about half of the people had used a computer before. So it can be very empowering to put a tool in someone's hand and say, I believe you are the expert on working in your organization. Let's learn together what we need to do to adapt this tool for your organization. There's an old school idea that this design and planning work would all happen in one phase, and then later that would finish and there'd be an implementation phase. But with this approach, that boundary is completely broken. You're going through cycle and cycle of, as the workers become more expert at using their technology, they're uncovering new possibilities, new ways it could be used. And you're also realizing constraints that you hadn't foreseen, but that you may need to pivot to accommodate. There was a good example of that in a project I'm working on in Kenya right now. This is a fancy thermometer. It plugs into the fridges where vaccines are stored at rural health facilities, and it takes automated temperature readings. It's also connected to the mobile phone network. So if something goes wrong with the fridge, the thermometer can let you know. And when we started the project, we thought that the data collection features might be the most powerful part of this device. There was this old practice of nurses opening the fridge, looking at thermometers, writing down temperatures, and then submitting them at the end of the month. We thought we could automate all of that. But over the course of several months, as they were using this tool, we worked with them and began to see that their process for manually checking the temperatures was important to them because it was very much tied up in other work practices that related to just maintaining the fridge so that it would stay in good working order. What we found instead for them, from their point of view, this device was incredibly helpful when you go away for the weekend or you just haven't looked at your fridge in a while. If something goes wrong with it, this device can send you a text message alert. And we realized that we needed to pivot this project to refocus not on automating data collection, but on these alerts so that they could coordinate a faster response when something does go wrong with the fridge. The final insight I'd like to share with you from the human-centered design community is that we can learn a lot from extreme users. Now, if you were a designer at Twitter, for example, your extreme user might be that guy who always has Twitter open and he's posting 200 tweets a day about all the TED-Talks he's watching. But in working in global health, there's a different extreme user. I'm talking about going to the places that are hardest to reach, finding communities that are the most marginalized, and choosing to do your design work there rather than anywhere else. In truth, there are very few health experts who dare to make the journeys that we often expect ordinary patients to make in the rural developing world. But I have a time or two made those journeys myself, and at the other end of the bridge, I found in even the most remote communities, there are community health workers, and they make phenomenal design partners for two reasons. One is that they live in the same remote villages and under the same socioeconomic circumstances as the people they're serving. You see, they're recruited and given on-the-job training to provide healthcare closer to the patient. The other reason they make great design partners is that a big part of their work is accompanying those who are sick. And so they accumulate not only the illness experiences of their family, but of their whole community. And they have that perspective on these interactions with the health system. This is the kind of phone most community health workers that I've met in countries all over the African continent own. It's not a smartphone, and it's not the future of mobile computing, but it is very durable, and it has a battery life of as much as a week or 2 weeks. And that's incredibly important when you live in a place with such poor access to electricity that you might need to walk a few miles and give your phone to someone at a shop in order to get it charged. The conventional wisdom with these phones is that they don't do apps. So you can have text messages, you can have voice phone calls, but if you want to really deal in health data, you'll need a smarter phone. This conventional wisdom never made sense to me because I would see mobile network operators putting apps on these phones, kind of silly entertainment services, or you could get a weather report or news headlines. And I thought, there's got to be a way to do that for health. And eventually I learned what they were doing was putting apps not on the phone, but on the SIM card, on this little chip that goes into the back of your phone. And because they were on the SIM card, they could work on any phone out there. So I tried for a long time to get mobile network operators on board to empower frontline health workers and never crossed that bridge. But what ended up happening is I discovered a small manufacturer just outside of Prague that was producing a different kind of SIM card. It's called a parallel SIM, and it's paper thin. So you can put your health apps on it and then slide it right underneath a standard SIM card. And with this tool, you can have data collection apps on any phone. We're now working with health workers in about 6 countries to submit their routine reports in this way. I'd like to close with an image of hope. My colleague Megan Orton sent me this photograph of a woman who had recently given birth. And you can see her face lit with appreciation for the community health worker who accompanied her throughout her pregnancy to the clinic this day. And this mother may not know very much about our communication program, but in the face of the community health worker, you can see she's glad to be well equipped for this work. I believe that the next step for global health is to put a phone in the hand of every health worker. I think she'd agree with me, and I'd like to invite all of you to join us. Thank you.